Hello, my name's Susan Murphy. I work with the Professional Practice Department, and the area I cover is the Mental Health Program and the Behavioral Support Transition Unit. Today I'm going to talk to you about management of workplace violence with the goal of promoting a safe work environment for both staff and patients. Prevention of violence in the workplace is everyone's responsibility. Multimodal strategy is required with different levels of governance introducing mechanisms to keep workplaces safe. Success requires participation from multiple stakeholders at all levels, including directors, managers, supervisors, both clinical and non-clinical employees, human resources, joint health and safety committees, occupational health and safety, as well as protection services. You as the frontline worker are at most risk for being affected by workplace violence. So our goal today is to help you understand what processes are in place at Quinte Healthcare to keep you safe and what the expectations are for you as it's related to this. Under the Occupational Health and Safety Act, hospital organizations must have mechanisms in place so that all patients are assessed for risk of violence. If risk is identified, it must be communicated to others, and this is usually accomplished via a flagging protocol. Also, any patient exhibiting high-risk behaviors must have a documented care plan initiated. This ensures staff are aware of how to provide care in a safe manner. Quinte Healthcare has implemented the dynamic appraisal of situational aggression, also known as the DASA, as an assessment tool to help staff identify patients who may be at risk for becoming violent. We communicate this risk to others through a behavioral alert. Determining when violence will occur can be a very difficult task to predict accurately. However, using a tool which assesses dynamic factors is far more reliable method of determining risk state. Dynamic factors are those which are fluid, may change, and are often situational. The DASA has 7 items which are assessed, and you will score 1 point for the presence of each item. The items are irritability, impulsiveness, unwillingness to follow directions, sensitive to perceived provocation, easily angered when requests are denied, negative attitudes, and verbal threats. The tool is ideal because it can be completed rapidly and it doesn't require advanced skill or a lengthy interview. That being said, there are some specific limitations that you should be aware of. First, not all patients who are identified as a risk will actually become physically violent. The tool is also inaccurate beyond a 24-hour period. Therefore, it requires reassessment every 24 hours to remain valid. The tool is also restricted to inpatient settings because it requires observation of the patient over a 24-hour period. And lastly, the tool has been validated in mental health populations. That being said, the DASA assesses a state of irritability and disagreeableness. This is a state common to many acts of aggression, irrespective of mental health concerns. The assessor must understand how it is represented in other clinical populations, such as dementia. When to complete the DASA. The standards of care around the use of the DASA has been customized to the needs of specific locations. These are the emergency department, inpatient units, and the mental health program. In the emergency department, all patients are screened at triage to determine if they are presenting as a risk of harm to others. If the screen is positive, the triage nurse must complete the DASA. A positive score will notify staff electronically that there's a patient at risk in the department, which allows them to plan and mobilize supports as necessary. If the patient is not presenting as a risk at triage, but subsequently demonstrates risk behaviors later on, the ER staff would complete the DASA as necessary. Inpatient units are not required to complete the DASA on all admitted patients, but nursing staff must initiate it on an as-needed basis if risk behavior occurs. Staff working on the mental health unit are expected to complete the DASA on all admitted patients, and also upon the emergence of any risk behaviors during the patient's admitted stay. We have established risk of harm criteria for the types of behaviors that may require a DASA to be completed. Keep in mind this criteria is not inclusive, and there may be other types of behaviors not represented here that would also require an assessment. The nurse uses their critical thinking skills to know when it is appropriate to complete the assessment. Examples of the types of behaviors that would prompt completion of the assessment are acts of physical or verbal aggression, destruction of property, speech that is rapid, loud, or profane, body language that appears threatening, increased disorientation or confusion, motor agitation, such as pacing or inability to sit still, hallucinations that may be benign or command, extreme or labile affect, such as exhilaration or grandiosity, presence of intoxication from alcohol or drugs, especially if it is coupled with any of the behaviors mentioned. As well, if you have been notified of a recent history of violence prior to the arrival or admission to hospital by police, family, or persons accompanying the patient, you would also complete the DASA. As mentioned, there are 7 items to score on the DASA tool. When you're completing your assessment, scoring is based on your knowledge of the patient and observations of the patient during the previous 24 hours. Score 1 for the presence of an item or 0 for its absence. A very important caveat is that well-known patients who are never physically aggressive but whose habitual behavior would score positive are only scored for a 1 for an increase in the behavior that's described. And habitual behavior, while being non-violent, is scored as 0. Generally speaking, patients considered to be well-known are those that have been admitted for at least 7 days, such that a pattern of behavior can be trended and established. For example, a patient who has been admitted for several months and is known to staff is always irritable and unwilling to follow directions, but never physically aggressive or violent. They would score a 0 on these items. However, if the patient is not generally this way, but they have behaved this way in the last 24 hours, then you would score them as a 1. Anytime you have a patient who is not well known to staff, which would often be the case in short admissions, they would be scored as a 1 for presence of an item or 0 for its absence. Now we will go through each individual item to ensure understanding of the definition. Irritability. The patient is easily annoyed or angered, or the patient is unable to tolerate the presence of others. An example of this may be a patient who becomes easily overstimulated by a co-patient, or perhaps the patient becomes annoyed or upset when a clinician is in their room doing seemingly innocuous patient care activities, such as blood work. Impulsivity pertains to the inability to remain composed and directed. People may be prone to having a hair trigger reaction, whether it be affectively or behaviorally. They may be quick to overreact to real or imagined slights, insults, and disappointments. Both their positive and negative reactions can appear exaggerated or overdone. Their actions are markedly inconsistent and hard to predict. Responses are not in line with usual expectations given the circumstances. Unwillingness to follow directions. Acts of aggression often occur following a demand, where the patient is motivated to avoid the demand, or where they are annoyed by having to do something they don't want to do. Perhaps the demand is beyond the person's current capabilities, such as in cases of dementia, and they are unable to follow the direction. Examples of demands may include things such as having to wait for something or being asked to participate in ADLs. Sensitive to perceived provocation. Acts of aggression often occur following perceived provocation. Perhaps it may be the caregiver's approach or the patient's interpretation of something as unfair, unjust, or unwarranted. Provocation is subjective, and a patient's appraisal or sensitivity may differ from others. Easily angered when requests are denied. Aggression often occurs following the denial of a request that has been made by the patient. For example, when a patient requests a pain medication and they do not receive it in a timely manner. Another example would include dementia patients who exhibit responsive behaviors when they ask to go home and they are denied the ability to leave the unit. Some patients are unable to understand and accept when requests can't be fulfilled or when they may need to wait. However, others may respond with anger because they perceive the denial to be insulting, unreasonable, irritating, or provocative. This may or may not be the case. It is subjective and will differ from person to person. There are also those patients who will respond aggressively because they feel this may force others to grant their requests. In this case, their aggression is instrumental and relates closely to our next item, which is negative attitudes. Negative attitudes. This item can be difficult to score accurately. The assessor must interpret the person's attitude and beliefs towards people, social agencies, rules, or authority based on the manifestations of their behavior. One is not able to determine if the behavior manifestations are a stable trait or if they are responding this way because of a trigger, such as a crisis or acute stress. The assessor needs to determine whether there is a lack of empathy towards others, the person's behavior or actions are callous in nature, they lack remorse for the negative impact they have on others. People expressing homicidal ideations or those who are expressing paranoid delusions or beliefs of being persecuted by others would also score positive on this item. Verbal threats. We know from the behavioral escalation continuum that verbal aggression often precedes physical aggression and that they are closely related. For this item, verbal aggression may include a verbal outburst. The person may shout angrily, insult others, or curse. Moving forward, we are now going to look at the assessment tool as it is seen in Meditech. You can see the items are listed and you enter a 1 for the presence of an item or 0 for its absence. At the bottom of the screen, the score automatically tallies and generates a risk score. The generated scores inform level of risk and also direct the following actions. A score of 0 to 1 indicates low risk and no remedial action is required by the caregiver. Patients scoring a 2 or a 3 are considered moderate risk, and the nurse is expected to apply a behavioral alert to communicate this risk to others, and also to increase their monitoring of the patient. The patient is to be reassessed every 24 hours. Patients scoring 4 or higher are considered high risk for imminent aggression. Nursing staff are expected to apply the behavioral alert, increase their monitoring, reassess every 24 hours, and initiate care planning for the patient. Reassessment and discontinuation. As mentioned, patients are reassessed every 24 hours because the score is only valid for that interval of time. Nursing staff continue to reassess until the patient meets the threshold to where the assessment can be stopped. Discontinuation of the assessment can occur after the patient has scored less than 2 for 3 consecutive days. The nurse would remove the behavioral alert notification at this time. Nursing staff would reinitiate the assessment if there is an emergence of risk behaviors, and they would also direct their care based on the risk score that is once again being generated. Communication of risk is done via a behavioral alert. Our symbol for behavioral alert is represented by a purple triangle. There are stickers and signs available on the units with this symbol. You should be placing a behavioral alert sign outside of the patient's room and/or above their bed, and also be placing stickers on the spine and front of the patient's chart. Where charts have not been assembled in binders, such as the case in emergency departments, the sticker should be placed on the paper copies of the chart. You should also place stickers beside the patient's name on the interprofessional round boards where care planning is discussed. Behavioral alert statuses should also be indicated in the electronic medical record by transcribing this in the administration data screens that are used for transfer of care between shifts, and also on the SBAR for transfer of care between units. Now we will move into care planning expectations. Patients scoring 4 or greater are at imminent risk and require a formalized care plan. Care plan development will not begin until the patient has been admitted to an inpatient unit. If a patient is identified at risk in the emergency department, it will be communicated that a care plan is required through the SBAR. The most responsible nurse will begin care plan development. An important piece to this process is the involvement of patients and families in the plan of care. This will foster the development of alliance with the goal of working together to reduce incidents of aggression in the future. Currently, our behavioral care plan is developed on paper. It should be completed by the most responsible nurse in collaborations with patients and families and input from the interprofessional team. The care plan should be updated accordingly as needed and also be kept in an area where it is accessible to the frontline staff. An ideal spot would be to place it alongside the patient's CMAR. Nursing staff should ensure that the care plan is also accessible to unregulated healthcare providers who are assisting with care of the patient. Care planning involves a review of the relevant clinical factors which increase the likelihood of aggressive or responsive behavior. This serves as a starting point to direct further assessment that may be needed, and to inform your intervention strategies that you will outline further along in the plan. Think broadly about the causes of a person's behavior. Is there something organic that can be treated, such as the 3 Ds: delirium, dementia, and depression? We should be using behavioral strategies first. What would you keep in mind when caring for someone with problems with memory, language, recognition, or lack of insight? Is there any underlying delirium? Think of the acronym I-WATCH-DEATH to help you determine the causes of delirium so that it can be treated. Are we optimizing medications such as antipsychotics, benzodiazepines, antibiotics, antidepressants, mood stabilizers, or medications from sleep? Recognize verbal and physical behavioral indicators. Early intervention is the key, using some of the strategies learned in the de-escalation module. You may also enhance your de-escalation skills by signing up for courses such as nonviolent crisis intervention training or gentle persuasive approach. You can do this through the e-learning portal. Also consider what are the emotional factors driving a person's behavior. Understanding a person's emotions positions you to know how to respond effectively. There are 8 primary emotions: anger, anticipation or anxiety, joy, trust, fear, surprise, sadness, and disgust. It's the negative emotions such as anger, disgust, anxiety, and fear that are more often associated with acts of aggression. Although we don't think of them in this way, emotions are a result of an evolutionary process. Each emotion has a core function that serves a purpose. Emotions motivate us to act and respond to situations appropriately. Emotions can also be thought of along a continuum. They will manifest differently at opposite ends of the spectrum. The primary emotion of disgust may look like boredom on one end of the spectrum and loathing at the opposite end. Recognition of these differences can cue you to the intensity of the emotion, which can then be matched appropriately to the right intervention. We wouldn't respond to a patient who is bored in the same manner as someone who is loathing someone or something. Briefly touching on the negative emotions and their functions, think about how you might respond appropriately. The function of disgust is to motivate us to avoid and reject that which we believe is unhealthy. Fear tells us to avoid potentially dangerous situations, serving to protect us. Fear leads to high activation of the fight or flight response in order to prepare the body for survival. Sadness tells us that we need to act to seek help and connect with those who care. And anger arises when an individual is in a situation that produces frustration or that is threatening that which is important to them. It signals to us that we need to fight against that which is causing us problems. You will notice that when you couple more than one emotion together, it can produce an expected response. For example, when you couple anger with fear or anxiety, this can lead to aggressive behavior, lashing out, impulsivity, and loss of rational thought, which can increase risk. Recognizing and understanding the predominant emotions of your patients can guide you to more effective responses. Identifying a patient's known triggers can help you tailor interventions which will either help to avoid or mitigate the risks associated. Identification of triggers requires concerted efforts by the entire interprofessional team. Utilizing the dementia observation system or discussion during interprofessional rounds are recommended activities that can help establish recognized patterns of behavior. When using the DOS, you must complete a focus note anytime there is a responsive behavior noted in the legend key. Detailed information about the events surrounding the responsive behavior is needed for behavioral analysis and development of a tailored care plan that is specific to the triggers of the patient. Intervention should be focused on development of communication strategies, modifying the environment, having a plan for addressing concerns around ADLs, and developing engagement strategies. Effective communication is one of the most powerful interventions to prevent escalation, but it can also be one of the most difficult to master. It requires mindfulness about how you are communicating to others. Ensure that you are conveying compassion and empathy. Be careful not to dismiss or minimize patients' concerns. Avoid expression of frustration. Body language is the most predominant way we communicate with one another. People interpret body language more than they interpret the words or message that is being conveyed. Make sure you are speaking clearly at the patient's level, avoiding jargon, and don't outpace the patient. Allow for cognitive processing. Negotiating mutual expectations is one way you can restore power imbalances, allowing the patient a sense of control while fostering accountability for behavior. Avoid getting into a power struggle with individuals. Always maintain calm and professional demeanor. Validate the person's reality and their experiences. Give them your undivided attention. Performing ADLs is a task where responsive behaviors occur most often. Therefore, it is necessary that there's a plan in place to provide care in a way that is safe. Understanding the needs of hygiene, toileting, nutrition, mobility, dress, and sleep is essential. Are there schedules or routines to be followed? Is the patient independent? How capable are they? Is assistance of more than one person necessary for safety? Are there known strategies that may help? These all should be laid out in the plan of care. Environmental modifications are easy to implement, but are not often thought of as a strategy. Wherever possible, decrease stimulation in the room, adjust lighting, allow for more natural light or perhaps dimming the lights. Augment the noise in the room, turning off beeping IVs, or perhaps getting a radio might help. Consider room assignment. Is it possible to have a private room? Otherwise, ensure the assigned co-patients are a good fit who can provide welcomed companionship. Utilize memory or communication aids such as visual signage in the room that will help reorient. Perhaps observation and monitoring needs need to be adjusted due to safety concerns. Another thing to consider is visitor profile. Are there those that trigger the patient or alternatively help to calm? There is a new recognized model of providing care that is shown to reduce responsive behaviors. Montessori methods, which have been used in the educational setting for many years, are now being developed for those who suffer with neurocognitive disorders. Evidence supports that the primary reasons for responsive behaviors are boredom, loneliness, and not adjusting to the needs of the patient by matching activities that are suited to their capabilities. The goal in using Montessori methods is to be proactive and engage the patient before the responsive behavior occurs. The focus of interventions is to enable and support the patient to use their spared abilities, to adapt the environment to optimize feelings of familiarity and comfort, making it feel like home. By giving the patients meaningful things to do, you enhance function and self-esteem. We do this by ensuring that they are set up for success, by having them participate in activities that are within their capabilities. We choose activities that connect them to their own identity, roles, and interests, who they used to be. The criteria for success is allowing them to have enjoyment each day. One of the core tenets in the Montessori philosophy is to understand the person behind the disease. Understanding who this person is by obtaining a fulsome psychosocial history from family or those who know the patient well is essential. What is this patient's narrative life story? What do they like to be called? What are their favorite things, foods, and hobbies? Who do they identify as? What roles did they fulfill in their younger years? Were they a mother or an important community leader? What was their occupation? It's also important to know about mountaintop memories, those which are deeply ingrained. These could be positive memories or those that are traumatic and frightening. We can use the information we gather to tailor the patient's care and incorporate their past into their present, creating a memory box to use while reminiscing, taking them back to a positive place of joy. Having photos and pictures from home, maybe those from an earlier time when they were younger. These they will recognize more readily. You can incorporate artifacts from home into the environment. Maybe it's a blanket or something else that offers them comfort. Map activities that connect them to familiar routines from their past that they enjoyed. Maybe it's afternoon tea time, or recreating an activity that simulates an aspect of their former employment. Ensure when you are creating activities that they are suited to the patient's interests, skills, and ability. Using memory aids and cues can help support them in their environment. Provide signage and orientation in the room. Clocks, dates, times, activities, and schedules. The name of the nurse will help keep the patient oriented to person, place, and time, decreasing anxiety from not knowing what is happening around them. Wayfinding signs or cues can be helpful. Perhaps they forget what they are supposed to do. Often, communication is impaired, so having signs with familiar symbols may help. Patients often will revert back to their first language, so having signs with common words or phrases from the language they are speaking is an idea you can use. Often the most basic need to feel love and connection is missing in their lives. Another strategy that is often quite helpful in fulfilling this need is the use of a pet or doll therapy. However, the most effective means of achieving this is through therapeutic use of self. That is, to genuinely engage in a meaningful way, creating joy, engaging in laughter, and taking a moment out of your day to connect. Lastly, we want to engage, enrich, and enhance the function of their current capabilities. Enable them to do the things that they love to do and the things that they are still capable of. This requires some creativity on part of the caregiver to come up with strategies and supplies for activities. Consult your team and your manager about mobilizing things that can be implemented. Utilize recreation therapy that is available to you. There are a few ideas on this slide that can be easily replicated. For our last slide, we discussed the required elements of collaborative care planning. Patients and families are to be actively involved in the development of the care plan. When a patient has a behavioral alert status, they or their substitute decision maker must be made aware of this and provided with an explanation of the reason why. When discussing this with the patient or SDM, it is important that the conversation is framed as an opportunity to learn from one another. It is therefore important that we inquire about the causes or triggers for their behavior, allowing them to share their perspective experience. Working together to understand each other and prevent escalation in the future is the goal and message we convey. Care planning is an opportunity for alignment and to develop a truly collaborative plan. There is a pamphlet which explains the process and rationale for the behavioral alert that must be provided to the patients and SDM. This will help support you in your conversation while you answer any questions they may have. There may be worry and anxiety about this conversation making matters worse or triggering more aggressive behavior. However, evidence shows that this is not the case and it actually fosters development of rapport and reduces incidents in the future. There are some general safety precautions that must be taken to ensure that you are set up for success. Wait until the crisis is over and the patient is fully de-escalated. You can still initiate the care plan for the patient and bring them in when the time is right. Ensure you practice basic safety precautions such as taking an environmental scan of the room. Prior to having the conversation, remove any risks or go to a safer location. Go with support if you feel you need it. Ask your manager or team leader to assist. Make others aware if you plan to have the conversation alone so that they can be near and quick to respond if help is needed. Remember your communication skills. They are the strongest tool in your toolbox. Remember the skills learned in the de-escalation module. Remain open and non-judgmental. Be honest and focus on the issues. Redirect if needed in a polite manner and apologize if it's necessary. Look for a way to help the person save face. This is not about blame, it is about solutions. If you feel threatened, terminate the conversation and seek assistance about how to proceed. Use your code white procedures if necessary.